Hello, everyone. I wanted to talk to you today first about a dream, and maybe you can relate to me as we've all had them. Have you ever had a dream when you were a kid of becoming something? Like you knew exactly what you would become in the future, whether it be an astronaut or a pilot? Raise your hand if you actually had that dream growing up, yeah? And then keep your hand up if you actually became that or pursued that. I can relate to that, absolutely. When I was a kid, I dreamed of being a doctor. It was the only thing on my mind from like this small. Picture this. I was in my basement at my parents' house in Ottawa watching TV when the TVs were about this thick and this small, and I was glued to the screen watching Magic School Bus. And I was marveling at how these kids were going through the human body, dodging red blood cells, and I was stuck and perplexed at how the immune system was able to defend itself to foreign bodies. Very specific, I know, and I know what you're thinking. What an odd little kid. But that's the only thing that was on my mind. I was absolutely hooked on understanding the inner workings of the human body, even back then, and being a part of the healing process of others, playing a role as a physician. And I worked tirelessly, had long study sessions, one single all-nighter, never again, and made sacrifices until it happened. I got into medical school my second try. I was so proud, yay. And then I turned it down. I actually said no. I said no to a stable future, no to financial security, and no to a dream on paper checked every box for success. I was about to be the first physician of my family, a first-generation immigrant breaking down generational barriers. So then why? Why did I make that decision? And it's because as much as I aspired to be a healer and be a physician, I realized that the healthcare system wasn't always a healing place. In fact, for many, it was a place of great harm for Black, Indigenous, and many other racialized people. Have you ever heard the name Joyce Echaquan? Joyce Echaquan was a 37-year-old woman from Manawan, Quebec, and she was admitted to Joliet Hospital on September 28, 2020, with abdominal pain. And instead of being met with humility and dignity by her healthcare providers, she was met with hostility, neglect, racism. Joyce Echaquan recorded her experience at Joliet Hospital and live streamed it to Facebook. And luckily she did, because she captured the cruel and dehumanizing remarks at the hands of the people that were there to help her, heal her. And we captured the mocking. They dismissed her, and they made racist assumptions about her lifestyle, suggesting she was a burden. And the thing is, this is a direct result of systemic racism in healthcare. This is what happens when racial biases and prejudices go unnoticed, unaddressed. And this is not an isolated incident. It's a pattern. But Joyce's story sent shockwaves through the country and amplified a call for change that has always existed. And it led to the creation of Joyce's Principles, an initiative to address systemic racism in Canada in healthcare, and as well offer equitable healthcare to Indigenous people. It's a start. It's a great start, but progress is still so slow. And we'll see that reflected in so many other communities. Progress is slow. We'll see it in the Black communities as well. Did you know that Black women's pain and symptoms are more likely to be dismissed, disregarded? Studies have shown, in fact, in the Lancet by Howell and authors, that racial implicit biases can lead to mismanagement of life-threatening conditions like preeclampsia, which is already disproportionately represented in Black women. The harm doesn't end there. When we say racism kills, we mean it. Chronic exposure to racism has been shown to actually have a biological wear and tear on the human body. Picture this: a rock within a river, the river slowly eroding at the rock, piece by piece, pebble by pebble, until nothing is left. That's weathering. Dr. Arlen T. Geronimus coined this term to explain the exposure of exploitation and oppression on the body, of classism and racism on the black body, the black woman's body. For black women, this leads to earlier onset of disease, more severe outcomes, and actually reduced life expectancy. Racism kills. And these aren't just statistics, these are lived experiences. That of Charlene Irving, for example. She was an epidemiologist with the CDC, and she passed away from childbirth complications, avoidable, manageable childbirth complications. Despite the resources she had, despite the medical knowledge she also had. And so this showed that this is a systemic failure, not an individual action that is at the heart of the problem. So this is medicine. And her story isn't an isolated incident either. It's also a part of a pattern. And so this is medicine. This is how our healthcare system treats racialized people. This is how it treats us. This is how the system has failed us all. And it also is reflected in who was allowed to even occupy this space, who was able to enter into the system. Did you know that Black and Indigenous people couldn't become doctors not so long ago? Actually, as soon as 2018, it was still in the books that Black students couldn't become doctors. 2018. So in 1918, what happened is a lot of medical schools in Canada banned Black students from enrolling into medical school. And this rule and law and policy, this exclusionary policy, went unnoticed, forgotten over time. And it wasn't until a PhD candidate, Edward Thomas at Queen's University, uncovered it. And that led to the acknowledgement and formal apology. But this is just to say that this was not so long ago. And it's no surprise that these exclusionary policies are still felt today. Yes, it's represented in the disproportionately low number of Black physicians in Canada, but it's also represented in the experiences and the barriers that students face when they decide to pursue this career. And so as I reflect on all of this, I'm left wondering, is this medicine? Really? Is this how I will be a part of a system, and will I continue to perpetuate the inequities and the harm that I'm witnessing? I didn't want to. I wanted to first take a break and reflect on how I could be a better physician to serve my communities as a Black, women, Muslim, and settler. And so it took me down a different path and a different journey. I entered an essay competition, why not, in 2021. And I wrote an essay titled Colors in Medicine. And it was an opportunity to explore these gaps further, these gaps of underrepresentation, of inclusion, of equity, and actually earned second place, so yay. But it wasn't just a contest to me. It wasn't just an essay. It was my first opportunity to really unpack the realities of underrepresentation and what it means for these absences in the future of healthcare. Yes, I got to know more about the topic and delve into it further, but more than that, I gained a sense of purpose from this. It was the first ripple into my career of challenging the status quo and hopefully being a part of the solution and not the problem. And it inspired me to want to look at these core issues of inequity further. And so I turned to looking at systems, the systems that perpetuate the harm. And the most pervasive tools in these systems is data. Data numbers are often thought to be objective, neutral, and indisputable. That isn't the case. Not at all. Because without critical analysis and the right social and historical context to understand how the health outcomes were shaped, we can't just use data, because it would only further perpetuate the inequities that it seeks to measure in the first place. And so during one of my classes at McGill University, I explored this further. It was a course on intersectionality, racism, and health equity, taught by Dr. Ananya Banerjee, and it changed everything for me. It's where my peers and I got to explore the topic of race-based data further for the first time, and we published. We published in the Lancet, a world-renowned journal, with our thoughts and opinions on what race-based data is and what it has the potential to do. We talked about how it is so important that we define how the way we define, document, and analyze race-based data is going to shape the way that we perceive and talk about the health outcomes of marginalized people. We talked about, yes, the advantages of race-based data. It could uncover biases, it could advance justice, and it could even inform evidence-based practices to address systemic issues, absolutely. It could also essentialize race, it could misinterpret the data because it often doesn't take into account the social and historical context. Let me give you an example. Historically, data has often been misused. That's not hard to believe, but with race-based data, it often sometimes coincided with periods of discrimination. And it's used across the world, including Canada and the US. And an example that I can provide is, in 1930, the US Census data added Mexican as a category. And it coincided with the period where President Hoover's administration scapegoated Mexicans during the Great Depression. And so this addition of a new racial category actually led to the forced deportation of 1 million Mexican and Mexican Americans. And so we need to think, when we're using race-based data, given its history of alienation, of exploitation, can it really accurately and properly measure and address racism and health outcomes? We delved into this further, a lot further. It could be an entire seminar, quite frankly. And we also went back to the very same classroom where we conceptualized this topic. And we taught. We were invited back as lecturers. We taught to public health students. And the energy in the room was palpable. The frustration that the students felt at the current state of the world, at wanting to change the status quo and challenge these systems, was so inspiring. And it reinstated in me the knowledge that every single individual has the ability and the potential to create lasting change and impact. It reminds me of an African proverb, actually. If you think you're too small to make a big change and a big impact, you've never spent the night with a mosquito. Right. And it inspired me even further, because now I want to also consider how we talk about race, how we talk about these poor health outcomes. Looking back, I'm so happy that I said no to that dream that we initially raised our hand for. So grateful. Because it allowed me to better understand the health disparities and the health outcomes that I want to be a part of addressing. And now today, what I wasn't before, as a researcher, a tutor, a mentor, a teacher, I'm not giving up on that dream of becoming a doctor. I'm becoming a better one by questioning the norms, addressing biases, and advancing equity. I'm preparing to serve my patient in a way that truly respects their humility and their dignity. Because it's not enough to just be a doctor. It's 2025. It's about becoming a better doctor, a good doctor, an anti-racist, culturally safe, compassionate doctor. And so I have 3 key messages to leave you with today. First, to everyone in the audience that is a healthcare professional, healthcare provider, a medical student, the healthcare system is not perfect. It harms and it has harmed, and it may continue to do so, but you have the power to change that. You can change that with small, deliberate actions that create lasting ripples. Challenge the norms, advocate for change, be the mosquito, and question yourself. How can you do better? How can you be better? It's not just about the technical skills you can gain and the medical knowledge. That's important. But more so, it's about learning how to see people and patients as a whole person, shaped by their experiences, their cultures, their histories. And let vitality remind you that it's not about treating an illness. It's about promoting well-being so that you can create spaces where everyone can thrive, your patients and yourself. To healthcare institutions who are definitely in the room with us today, you've caused harm and you've lost the trust of communities. Race-based tools, outdated curricula, and discriminatory admission policies play a key role in that. And while progress has been made, there's so much more to be done The ripples of colonialism, of slavery, of discrimination, of mistreatment are still present today, are still felt today. And we can't ignore that. Acknowledge it, name it, dismantle the harmful practices, and take urgent and tangible action to revise the curricula, to center anti-racism, to eliminate racial bias in clinical decision-making, and to diversify leadership at every single level. Ensure accountability. Health equity cannot be a passive goal. It has to be an active, relentless commitment. And to everyone in the audience today, I have one last message for you. Each of us, no matter our backgrounds, our profession, we have the power to create these ripples of change. We can start a conversation that can challenge a bias. We can lean into that uncomfortableness. We can unlearn and rebuild, because we all play a role in shaping a more equitable healthcare and a more equitable world. And the change doesn't even have to be monumental. It could be the smallest action or the smallest conversation. Just know that it can grow into something immense. And just ask yourself today, whether in this talk, in your seat, or throughout your day, what kind of ripple can you create? I hope that we can face these challenges together, because they are crucial. I know that I'm committed to try to be a part of the solution, whatever form that may take. And today, yes, that's as a candidate MD PhD student, but tomorrow, maybe something else. But just know that no matter what you do, you have the potential to shape a more equitable healthcare system. So let's continue to ask those hard questions, challenge the status quo, work together to create a future where healthcare truly does serve everyone. And with that, I'll leave you with the words of James Baldwin. Nothing that is faced can be changed. Not everything that is faced can be changed, but nothing can be changed until it is faced. Thank you.